ability to talk on this very important aspect, approach to flow cytometric immunophenotyping of acute leukemias. So this is the outline of my talk. I'll be sharing a few screens, a few slides on the introduction to flow cytometry in brief. Then the comparison of flow cytometry versus immunohistochemistry, then acute leukemia and its types. Very importantly, approach to blast identification, and then discussing a few cases. So I've been given 1 hour. Let's see if I can do justice to this topic in 1 hour. So what is flow cytometry? It is measuring properties of cell as they flow in a fluid suspension across an illuminated light path. It is an amalgamation of 3 components: fluidics, which makes the cells flow in a single file; optics, which is the part which generates light and collects the light signals; and electronics, which converts the data into electrical signals. So this is how the cells pass in a single file. It is intercepted by the laser light, and it is then the light is scattered in the forward angle and at 90 degrees. This is then collected. This then passes to the filters and is collected by the detectors. So when there is a biological sample, which can be a fluid sample, which is blood or bone marrow or any fluid, or even the FNAC samples, the cells have to be suspended in a liquid media. The sample is then processed, that is stained, wherein it is labeled with a fluorescent marker. The cells move in a linear stream through a focused light source. The fluorescent molecules get activated and emit light that is filtered and detected by sensitive light detectors. And there is conversion of analog fluorescent signals to digital signals. This is what happens when we are actually doing flow cytometry for any specimen. There's a technique called hydrodynamic focusing, which is the backbone of how the cells pass in a single file. So the cells are pushed under a pressure, and then individual cells are then intercepted by this laser light. The light then passes through various detectors and filters. This is in very brief the principle of how a flow cell and a flow cytometer works. Now, what kind of data can be generated by a flow cytometry? So as you've seen, the light can be scattered in forward angle and in the side and at 90 degrees. So light, when it goes in a forward scatter, it tells us about the size of the cell. So if the cell is small, forward scatter will be low. If the cell is big, the forward scatter will be high. The second signal is the side scatter, which tells about the granularity of the cytoplasm or even the nuclear complexity. So a cell which is small in size, like a lymphocyte, will have a low forward scatter and a low side scatter. Whereas a cell which is large in size will have a large in size and has granules. It will have a high forward scatter and a high side scatter. Then we are also tagging the cells with antibodies which are fluorescent conjugated, with are fluorescently labeled. So a cell will have a lot of antigens, and depending on what all antibodies you are using, it will be giving out signals. Therefore, in a single cell, we can have a forward scatter, a side scatter, and a lot of other fluorescence, depending on how many antigens and antibodies we are looking at. This is one of the very basic dot plot, the forward scatter on the x-axis and side scatter on the y-axis, which we all see in our initial classes of flow cytometry. What we can see here is that these are lymphocytes, the smallest cell size with smallest forward scatter and smallest side scatter. Then we have these granulocytes, which are larger in size, and they have granulocyte, they have higher side scatter. And then there are monocytes in between, which have a moderately high forward scatter and a moderate side scatter. Now, what is gating? Gating is essentially selecting cells of interest. You all have heard that in this gate, the cells were gated here, the cells were gated. So what is gate? So gate is actually when you instruct the software of the flow cytometer that I'm selecting this population. For example, on a forward and a side scatter, I'm selecting this population, which is the granulocytes, and asking the software to tell me the characteristics of this population. So the software might tell me that this granulocytic population comprises about 68.8% of all the cells here in this dot plot. And it will also be able to give you the median channel for the forward scatter and the side scatter. Similarly, on a CD45 versus side scatter, we have cells falling into different areas. We can make regions or gate around it, and then the software will tell us about these populations. Now look here again, this is a contour plot of a forward and a side scatter of a whole blood. We can see granulocytes, monocytes, and lymphocytes here, and we understand by experience that this population probably is debris, and I want to get rid of this debris. So I will make a region around here. On a CD45 versus side scatter, if I see this population, we'll see that the debris is, or unlike RBC, they are negative for CD45. I don't want this population further analysis, so I'll make a region around it and instruct the software that exclude this from the further analysis. So that is one way to use the gates. And then this is a forward scatter area versus height dot plot. And you can see that the cells are falling in this diagonal. Now, if the cells, some cells are lying here, that means there are doublets. I don't want to see doublets in my further analysis. So I'll make a region around this population and instruct the software that do not show me cells which are outside of this region. And this helps me to get rid of the doublets. So we can get rid of the doublets here. We can get rid of the debris here. And obviously, in our analysis, we'll need to find out what are the properties of this cell population, of this cell population, and this cell population. So we need to make regions or gates around it. So what is unique in flow cytometry? It is multi-parametric. That means for a single cell, you can see multiple parameters simultaneously, like its size, its complexity, granularity, and the number of antibodies which are tagged onto the cell surface. It gives a rapid analysis of large number of cells. So lakhs and millions of cells can be analyzed on flow cytometer in a smaller time. It gives information at a single cell level. And you can detect rare cell population. This is very of immense importance. For example, when you are looking at stem cells, or when you are looking at a minimal residual disease in cases of treatment. So flow cytometer can help you detect cells in single cell in 10,000 or 1 lakh cells. It also allows physical isolation of cells of interest through sorting. Now, we all are very aware of immunohistochemistry. Flow cytometry and immunohistochemistry are two techniques for immunophenotyping of our cells of interest. And both have their own advantages and limitations. None is less than the other. So let us see what these two offer. Flow cytometry is laser-based technique and IHC is microscopy-based technique. Flow utilizes laser as a light source, whereas IHC uses lamp. Analysis in flow is using a computer, whereas in IHC, it is viewed under a light or a fluorescent microscope. Flow cytometry, biggest advantage is that it has a short turnaround time. It is a faster system. You put in the sample, get the sample in the morning, and by evening, you know which kind of leukemia or lymphoma you're handling with. IHC will take 2 to 3 days. Detailed immunophenotyping is possible by flow cytometry, mainly because there is a large number of CD markers available now. IHC also, we can do large number of CD markers, but it is much less as compared to flow cytometry. Now, quantitation of antigen and its intensity is possible objectively by flow cytometry, whereas in IHC it is subjective. If you wish to see the maturation patterns, it is possible by flow cytometry, but not by IHC. Whereas, if you want to see the morphology and architecture, it is only possible by IHC and not by flow cytometry. And the data can be archived in flow and tissue can be archived in IHC. Therefore, if you want to do further testing, further assays, you can do it on the paraffin embedded tissue, whereas in flow cytometry, it is limited. Now coming to the actual topic of acute leukemias. What are acute leukemias? These are neoplastic proliferation of precursors, lymphoid of myeloid cells, which are termed as blasts. Acute leukemias are typically acute in onset, and there is uncontrolled proliferation of precursors, usually in the bone marrow. which replaces the normal hematopoiesis, leading to cytopenias and related symptoms. Spillover in blood leads to leukocytosis, but uncommonly leukopenia, which is also known as aleukemic leukemia, and it happens because of the packed marrow. So marrow is so much packed that the cells are unable to come into the blood, and it leads to leukopenia. Now coming to the classification, we all know that acute leukemias are broadly classified into two types, lymphoblastic and myeloid leukemias. In the lymphoblastic leukemias, WHO has classified them into precursor lymphoid neoplasms. The fourth edition classifies it as B lymphoblastic leukemia lymphoma NOS, then B lymphoblastic leukemia lymphoma with recurrent genetic abnormalities, and the recurrent genetic abnormalities are given here on the right side, which are more or less same in the fifth edition also. And then T lymphoblastic leukemia and its subtype early T cell precursor T lymphoblastic leukemia lymphoma. In the revised fifth edition, the updated fifth edition, which is now coming up, the ENCO lymphoblastic leukemia lymphoma has been removed. And we'll not go into details of the new classification system. I'll just touch upon certain things. As far as classification of acute myeloid neoplasms is concerned, AML has been classified into recurrent genetic abnormalities, then AML with myelodysplasia related changes, then therapy related myeloid neoplasms, and AML not otherwise specified, myeloid sarcomas, and myeloid proliferation associated with Down syndrome. This has been revised in the fifth edition, but on flow cytometry, what you can actually just make out is that whether the neoplasm is an AML or an acute promyelocytic leukemia, or AML with monocytic maturation, AML with erythroid differentiation, AML with megakaryocytic maturation, acute basophilic leukemia, or a mixed phenotype acute leukemia. Now, what are the steps of acute leukemia diagnosis by flow cytometry? Now, these are very important in the initial years, how you are approaching acute leukemia. So first is to identify the progenitor population. Then confirm that it is a progenitor population. Assign lineage to this progenitor population, whether it is B or T or myeloid. And then confirm how it is different from the normal counterpart. So what should a panel comprise of? A panel depends on the type of flow cytometer you have, the number of fluorochromes you can read in your specific flow cytometers. But essentially, it has to have gating antibodies, which is most commonly CD45 or LCA. This assists in identifying cell population based on CD45 versus site scatter. Then a panel should have markers to confirm that these are blasts, then markers to assign lineage, and then markers to confirm whether the given population of blasts is different from normal counterpart. That is, there can be cross lineage expression or aberrancy or abnormal maturation. And how extensive your panel can be depends on the type of instrument which you have, whether it is a 4-color, 6-color, 8-color, 10-color, 12-color, and so on. So obviously, the more markers you can add to a tube, the more extensive your analysis can be. What are the common markers for lineage assignment? For progenitors, most commonly used are CD34 and TDT. Other markers which can be used as progenitor but are also seen as activation are HLA-DR, CD38 and CD123. The myeloid markers commonly used are cytoplasmic myeloperoxidase or MPO, CD13, CD33, CD117, and CD15, which is a marker for maturation. On monocytes, one can assess CD64, CD14, CD4, CD33, CD11C, and so on. And CD14 is a marker which comes in mature monocytes. For megakaryocytes, commonly used ones are CD41 and 61. For erythroid, CD235A and CD71. For B lymphoid, CD19, CD10, 20, 22, and CD79A. And for T lymphoid cells, CD3, surface expression as well as cytoplasmic expression, CD2, 5, 7, 4, 8, 1, 8, 99, and so on. So the marker list can be extensive, as I earlier said. Now, how do you identify blast? Most commonly used is the CD45 versus side scatter strategy. The other way is to use a CD34 versus side scatter, or a CD34 versus 19, or a CD34 versus 3. It depends on case-to-case basis. If on a CD45 versus side scatter, you cannot see a blast population clearly, but you can see on some other dot plot, you can use that as well. So gating markers are the markers which are common in all the tubes of an experiment. In my 8-color panel, I have CD45 and CD34 as gating marker in all the tubes. Now, this is the most basic important plot for acute leukemia diagnosis. This is a CD45 versus side scatter, and CD45 on the x-axis and side scatter on the y-axis, or it can be other ways also. It just depends on how comfortable you are. So if you look at this dot plot, this blue population, which has a higher CD45 and a lower side scatter, is the lymphocyte, mature lymphocytes. Slightly lower CD45 and a moderately high side scatter are the pink colored cells, which are monocytes. These are the maturing granulocytes. This is a bone marrow specimen, just remember. So these are the maturing granulocytes. They have a dimmer CD45 and a high side scatter. Next to these are the eosinophils. And then these are the events which are CD45 negative. These can be nucleated erythroid cells or some debris. And this region here, this represents the blast region or the blast hole. The red cells here are the myeloid precursors, are myeloid blast. They have dim CD45 and a moderate side scatter, not high, but a moderate side scatter. And these light blue ones are the B cell precursors, also known as hematogones, which appear to be merging with the lymphocyte population. So they have a dim CD45, and when they mature, they start gaining 45, and they have got a lower side scatter as compared to the myeloid blast. So this dot plot becomes the cornerstone of identifying blast population. Now, depending on which kind of case we are dealing, the blast population can be seen as in these dot plots. So look at this here. These are the lymphocytes. These are the granulocytes. And there is a significant blast population here in green. And on immunophenotyping, they were lymphoblasts of B type. Lymphoblasts of B type can be negative for CD45, or they can have a dim expression of CD45. Whereas usually in a T lymphoblast, the population is shifted more towards right. So T blast usually have a brighter CD45 as compared to the B blast. Now look at the myeloblast here. You can see that the myeloblasts have got a moderately high side scatter, and they are seen to be merging with these populations of monocytes and granulocytes. Coming to this population of promyelocytes are larger cells and they've got higher side scatter because of the intense granularity. They are higher up on a side scatter and they seem to be merging with the mature granulocyte population. Another two plots here. You can see that the blasts here have dim CD45, and then this population is seen merging with the monocyte population as well as the granulocytic population. And this case actually was on FAB. It was actually myelomonocytic leukemia. Another one here, the blasts here have a higher side scatter and they are merging with the monocytic population, and this was an acute monocytic leukemia. So depending on where the blasts are sitting, you can have a fair idea from the beginning that what cells are we looking at. But then there are limitations of flow cytometric enumeration of blasts. What are the limitations? The exact enumeration of blasts is not possible because the sample is hemodiluted. Whenever we are aspirating marrow, we are aspirating out some blood along with it. So the sample is hemodiluted. Some nucleated red cell precursors may be lysed during processing. And denominator used in flow cytometry CD45 positive events. Whereas when we are doing morphology, we see the blast as a percentage of total nucleated cell count. Therefore, morphology is the gold standard for blast enumeration, specifically in the marrow. And flow should be used to characterize the blast rather than enumerating the blast. But then there are caveats to this, and we should be knowing it so that we do not commit mistakes. Not all blasts will be sitting in blast region. Here you can see that the monoblast and promonocyte, they have a higher CD45 as compared to the other blast, and they seem to be merging with the monocytes. How do we confirm whether they are monocytic blasts? They will be expressing bright CD33, CD64, and CD4, which are monocytic markers, and absent to dim CD14, which comes positive only when the monocytes mature. So this suggests indirectly that these are monoblast and promonocytes and not mature cells. Similarly, in atypical promyelocytes of APML, the site scatter is high, and these cells can be detected by myeloperoxidase CD117 staining, and they are negative for the immaturity markers like CD34 and HLA-DR, because these are not blast, but they are blast equivalents. Now, there can be other cells in the blast region, like basophils, plasmacytic dendritic cells, and hypogranular myeloid cells. We should be knowing the immunophenotype of these cells so that we do not confuse them with the blast, although their numbers are quite few usually. So if we have in our panel CD123 and HLA-DR, we can segregate basophils and plasmacytic dendritic cells from the blast region. So in this blast gate, if we look at the HLA-DR and CD123, the cells which are CD123 positive but HLA-DR negative will be our basophils, and the cells which will be expressing both will be the PDCs. It is good to know what are the other cells which can fall in the blast region. Point number 3, not all blasts or equivalents are CD34 positive. Some myeloid blasts or progenitors may be 34 negative. So for them, other markers may be used like CD117 for myeloid blast, TDT for lymphoid blast, and monoblast and atypical promyelocytes are CD34 negative. Blasts may show aberrant expression of non-lineage antigens. So we need to know what are the commonly expressed aberrant markers. In BALLs, you can see expression of 13, 33, 2, 5, and 7. In AMLs, we can see expression of CD7, CD2, even CD19, PAX5, Cyto CD79A, CD56, and so on. In TALL, there can be expression of CD13, 33, and 117. So you can see that there are a good number of aberrancies which can be seen, and therefore we need to use extensive marker combinations so that we don't commit mistakes in assigning a lineage. But these aberrancies are very useful in that they help in identifying the neoplastic clone, because we do not expect normal cells to be having aberrant markers. And if we are not aware of the aberrancies, we can give an erroneous diagnosis of mixed phenotype acute leukemias. Now, blast abnormalities fall into 4 main categories. There could be abnormal intensity of an antigen expression. So antigen expression could be increased or decreased or absent. This is a normal bone marrow and this is a leukemic bone marrow. You can see here that the red cells are the myeloid blasts and they have a pattern. They are gaining CD33 and HLA-DR. There is a pattern to it. And there is a specific level up to which 33 and HLA-DR are present in these cells. Whereas if you look at this AML case, 33 is not there. 33 is absent in this. And HLA-DR is homogeneous. So this will help us in identifying that this is not a normal maturing population. This is an abnormal cell. Now then there could be asynchronous expression of antigens like immature cells showing mature antigens. For example, here in a normal marrow, we can see that the precursors which are 34 positive will not be expressing 15. And when they mature, 15 is expressed and 34 is lost. So these two together should not come. But here in this case, you can see that 34 is brightly expressed along with CD15. And therefore, this is an abnormal population. Now, there could be homogeneous expression of antigens usually expressed at varying levels during maturation. Again, here on 34 positive cell, you can see that 13 is heterogeneous. So some cells As they mature, they start gaining 13. Whereas in this case of AML, there is a homogeneous expression of 13, which is again an aberrancy. Then there could be expression of antigens of other lineage, like a myeloid blast should not be expressing CD5. And here in this case, this is expressing CD5. That means in a case of AML, where myeloid blast is expressing CD5, this is an aberrancy. Therefore, we need to know the normal maturation patterns to identify the aberrancy. And this comes with experience and a lot of learning. Now, how to look at your data? This is a very common question which we encounter. That how do you know that which is the positive population and which is the negative population? A quadrant-based approach. This is a simpler technique. In this, what do? We utilize unstained tube-based negative and positive cutoffs to give a percentage of population expressing a particular antigen. So an unstained tube, that is no fluorochromes are put, it is processed in a similar manner like a stained tube, and it is acquired on a flow cytometer. And we know that because there are no fluorochromes, so there should be no fluorescence, and the population should be in the double negative zone. Based on this, we instruct the software to make quadrant. And then when we run our stain sample, if it falls in the positive region, we call it positive. And the statistics from the software will tell us that how many, what percentage of cells are falling in the Q1 region, and therefore we get a percentage to it. And we can also get negative population like this. So this is not a preferred method now, but still widely used because of the ease of implementation. Because we all want to know how many cells are positive and how many cells are negative. Then there is a technique wherein maturation pattern can be assessed. It is an ideal approach, but needs in-depth understanding and elaborate panels. So what do? In this kind of dot plot, I have created a region around the lymphocyte as well as the blast. The red cells are blast, the greens are lymphocyte. And in my next dot plots, I see both the populations in one plot rather than making quadrants. And the lymphocytes act as negative control here. We know that lymphocytes should not be expressing 34 and should not be expressing 117. And my blast population is expressing both. Similarly here, the lymphocytes are splitting into B cells and T cells. And my blast population is also showing CD7 expression. So we have internal positive and negative controls here. This was the case of AML. In a case of BALL, I have created a gate around the granulocytes also, because I wish to see whether my cytoplasmic MPO is working here in this or not. So here in this case, the blast cells are negative for MPO, whereas my normal granulocytes are giving a good positive staining for MPO. And my blasts are showing cytoplasmic CD29A positive, similar to the normal B cells here. And the blasts are expressing CD10 and NG2, and this was a case of BALL. So this is how we can look at the data. And I have, for the ease of understanding, I have used a lot of dot plots with quadrants. And I understand that as you all continue to look at more data, you'll be able to understand how to interpret these multicolor data. Now, let's start with the first case. We have a series of cases, and how much time is there? Nearly half an hour has passed. Okay, so first case. This is a 4-year-old child who presents with pallor, fatigue, easy bruising, and severe bilateral leg pain or bone pain. The peripheral blood showed a hemoglobin of 7.5, WBC of 36, platelets of less than 10,000. The differential revealed 90% blast and 10% lymphocytes, and the blasts were medium-sized cells with dispersed chromatin, scant cytoplasm, and inconspicuous nuclei. This is usually a description for most of the blasts. Now, this is how the blast look like, slightly larger than the small lymphocyte, larger than the RBCs, fine chromatin, indistinct nucleoli, and a very scant amount of cytoplasm. Now, in the first dot plot, on a CD45 versus site scatter, as you can see, we have dated out the lymphocytes in green, monocytes in pink, granulocytes or neutrophils in blue, and red shows the blast cells here. Here in the statistics, you can see that the blast population is 86.7%. The rest of them are lesser in number. And on morphology, we looked at about 90% blast. So this is roughly correlating with what we had seen in the morphology. Now looking at the individual dot plots, the blast cells are expressing CD19 and 10 together. Some population is expressing 34. Most of them are HLA-DR positive. CD20 is expressed by a fraction of cells. 13 and 7 are negative. 117 and 5 are negative. And 3 and 7 are negative. So we are getting B markers here, and this CD10 and 19 co-expression is quite characteristic of B blasts. Now looking at the cytotube, and this is the unstained tube. The cytotube is showing DIM positivity for cytoplasmic CD9A. It is negative for myeloperoxidase CD10 and cytoplasmic CD3. So to summarize, there were 90% blast on morphology, lymphoid-like. On a CD45 versus site scatter, we saw that they were about 86.7% blast, which exhibited a CD45 DIM. They express CD10, 19 HLA-DR, CD20, and CD34, and blast are positive for CD79A, and a diagnosis of precursor B-ALL, CALA positive, was given, and genetic studies were suggested for WHO classification. So we need to know the B cell differentiation and the way the markers come and go in a normal B cell. In a case of B-ALL, it is usually the most straightforward diagnosis, the B-ALLs, but it can be challenging when we are looking at a sample which has got hematogones or precursors, or when we are trying to look at MRD or minimal residual disease in a case of B-ALL. Therefore, we need to know the various stages of maturation of the hematogones. So in the stage 1, earliest hematogones will be expressing 19, 10, 34, 45, and 38, and will be negative for CD20. When they mature, CD19 is upregulated and it remains as such, more or less. CD10 starts to decline, and it declines further in stage 3 and in the mature cells. CD34 also declines rapidly in stage 2. CD45 is gained throughout, as you can see, and 38 is slightly upregulated and then downregulated in the mature cells. You look at CD20 here, it is negative in the initial phases, but then it is gained and becomes high. So these patterns can be actually seen here in the 45 versus site scatter. You can see there are 3 different blue populations. This is the most immature hematogone, stage 1, then stage 2 and stage 3, and you can see that they are gaining CD45. And then there are so many markers, 10, 38, 20, 45, 86, 24, which can delineate various stages of hematogones, but most easiest is this CD10 versus 20, which gives us a beautiful waterfall pattern. You can see that in the earliest hematogone, CD10 is bright, it then falls, and the cells start acquiring CD20, and then in the most mature phase, CD10 is lost. These are the mature B cells. So we need to know the various stages of hematogone maturation to pick up whether we are looking at hematogone hyperplasia or B blasts. Now, B-ALL is divided into various types based on the immunophenotype. The early pre-B, which has in which CD10 is negative or TDT is positive. The common ALL, which is the most common type, which expresses CD10. Pre-B ALL, in which cytoplasmic IgM comes up, and the mature B-ALL. Although we do not routinely categorize B-ALLs into these 4 types on flow. Now we come to the second case. This is a 14-year-old male who presents to his pediatrician with a 3-day history of wheezing and increasing difficulty breathing at night. On physical examination, in addition to wheezing, reveals axillary lymphadenopathy, pallor, and petechia. Chest X-ray reveals a mediastinal mass. The hemoglobin in this 14-year-old male was 6.9, WBC 41,000, platelets 15,000, DLC revealed 40% blasts, and the blasts were small to medium in size with high NC ratio, dispersed chromatin, inconspicuous nuclei, and scant cytoplasm. This is how the blasts look like, and They are essentially very similar to what we had seen in the previous case. Now looking at the CD45 versus site scatter, again you can see that there are these four populations: lymphocytes, monocytes, granulocytes, and the blast. And the blast here are more towards the touching the lymphocytes here. You could ask me, why haven't I gated this? This was actually gated, but then in further analysis, I realized that these were debris. So these were not further gated. Now these blasts, looking at their immunophenotype, they are negative for 19 and 10, negative for 20, some express 38. They are negative for 34, negative for 13 and 33, the myeloid markers, and negative for 64, 36, and 64, 14, which are again the monocytic markers. The blasts do not significantly express HLA-DR, but they are expressing CD7, they're expressing CD5, they are expressing cytoplasmic CD3, but cytoplasmic CD19 and MPO are negative. Now coming to more T cell markers, the blasts are expressing 8, but not 4. And some are expressing CD56. And surface CD3 is expressed by a minority of cell population. We can see that Q12 and Q22 are the surface CD3 expressing events, which are approximately 12 to 13% only. The megakaryocytic markers 41 and 61 are absent. And CD1A, which is a T cell marker, which comes in immature T cells, is also positive. So to summarize, there were 40% blasts on morphology, which were lymphoid-like. CD45 site scatter revealed 36% blasts that show a dim CD45 expression. There was moderate expression of CD7, 8, 38, 1A, dim CD5, and dim CD99. There was negative surface expression of CD3, 4, 10, and 34. But the blasts are positive for cytoplasmic CD3. There was aberrant expression of CD56. So what is this? This is a case of T lymphoblastic leukemia lymphoma. It is a clonal lymphoid neoplasm of immature T lymphoblast and may present as thymic, nodal, or extranodal soft tissue mass where it is known as a lymphoma, or it can present in blood and bone marrow when it is termed as leukemia. It is genetically and immunophenotypically heterogeneous, but subtypes are less well defined than B-ALLs or AMLs. It is less common than B lymphoblastic leukemia and comprises about 15% of acute leukemias, more commonly seen in teenagers, adults, and in males, mostly presents as lymphoma rather than leukemia. How do we diagnose? Based on morphology and immunophenotype. There can be sheets of blasts effacing the normal tissue. Blasts have the nondescript blast morphology. And you have to remember that morphologic discrimination between T and B blast is not possible. On immunophenotype, there will be cytoplasmic CD3 negative and with variable expression of other T cell markers, and may express markers of immaturity and variable expression of CD4 and 8. They can be dual positive, dual negative, or only one can be positive. This brings us to the case 3, which is a 24-year female who presented with left cervical lymphadenopathy for 1 month. Blood findings revealed hemoglobin of 7.8, 35,000 WBCs, 90,000 platelets, and again blast on peripheral smear 24%. These were again small to medium sized cells with inconspicuous nuclei and scant cytoplasm. Look at these blasts. They are again very similar to the previous 2 cases. Looking at the CD45 versus site scatter, the blasts are negative for CD45 and a low site scatter. Expressing 10 but not 19, expressing 38 but not 20, expressing 34. Some are expressing 33, the Q1 population here, about 30% of the total blast. 36 is expressed by a minority, and 64 and 14, the monocyte markers are negative. Then HLA-DR in 1 and 7 are absent. CD7 is expressed, which is a T cell marker. 4 is negative. 5 and 15 are negative. Again, a cyto CD3 is positive here. 4 and 8 are both negative. Surface CD3 and 56 are negative. The megakaryocytic markers are negative. 99 is positive, but 1A is negative. To summarize, 24% blast on morphology, lymphoid-like, blasts are CD45 negative. These blasts express CD7, CD10, CD99, CD38, CD34, and are negative for 5, 8, and CD1A. Blasts are positive for cytoplasmic CD3, but negative for surface CD3. So this combination of positive for cytoplasmic CD3, but negative for surface CD3, this itself suggests that these are immature T cells. Aberrant dim positivity for CD33 is seen here, and the rest of the markers are negative. So what is this entity we are dealing with? This is an early T cell precursor, ALL. This is a unique subset of T lymphoblastic leukemia, which has a unique biology and a poorer outcome. It is a neoplasm of early thymic precursors or early T cell precursors which retain multi-lineage differentiation potential. It has a unique immunophenotype and genotype, wherein there is limited early T cell differentiation, but retention of some myeloid and stem cell characteristics. So how do we identify TLLs and ETPLLs from normal T cells? So looking at these two dot plots, CD1A versus surface CD3 and CD8 versus CD4, we can differentiate normal T cells or thymocytes from TLLs and ETPLL. How? Normal thymocytes in the very immature state, they are negative for CD1A, then they acquire CD1A, they acquire surface CD3, and then CD1A is lost. So CD1 only in the intermediate stages. If you compare it with the case of TLL and ETPLL, you can see that the TLL will be expressing CD1A and ETPLL will not be expressing CD1A because it is derived from this cell population. Now, if you look at a CD4 versus CD8, the early T cells would be double negative for both, then they will acquire both, and then they will move in either CD4 or CD8 direction. In TLLs, CD4 or 8 both can be positive or it can go anywhere. But in ETPLS, CD4 and 8 are usually negative. So based on this, one can screen and then confirm the other markers. So what are the diagnostic criteria for ETP lymphoblastic ETPLL? It must show definite evidence of T cell differentiation. Like in this case, these are the normal T cells and these are the blasts. So the blasts are expressing CD7 and they are negative for surface CD3. And they are expressing CD3 here in this and CD45. So there is a definite evidence of T cell differentiation. The blast must show features of early thymocyte precursors. That means CD1A should be negative, CD8 should be negative, and CD5 should be dim or negative or expressed by less than 75% of the leukemic blasts. And they must not show evidence of myeloid differentiation. That means MPO should be negative and CD64 and 14, that is no evidence of monocytic differentiation should be seen. And they must express at least one stem cell or myeloid associated antigen. And this expression should be in more than 10% of the blast. So in this example, CD34 and 117 are positive in more than 10% cells. In this, HLA-DR is positive and in this 13 is positive. So these are the criteria for assigning a ETP-ALL phenotype to a cell, to a blast population. ETP-ALL has high frequency of myeloid-associated gene mutations like FLT3 and RAS-KRAS, DNMT3A, IDH1 and 2, and low frequency of typical TLL mutations like Notch1. This brings us to the case number 4. Can we just erase these red lines here? Okay, case number 4. This is a 65-year female with easy fatigability and low-grade fever for a month. She's been extremely lethargic. On examination, there is no lymphadenopathy and spleen was palpable. She has severe anemia. WBC count is 42,000. Platelets are 80,000 and differential shows 90% blast, which are large. They have round to irregular nuclei with fine chromatin, prominent nuclei, and cytoplasm has azophilic granules, and some blasts with OR rods were noted. Look at the blast cells here. They have granular cytoplasm and OR rods are noted in these blasts. So in morphology, we see that these are probably myeloid blast, and we need to confirm by flow cytometry. On a CD45 versus side scatter, we can again see that most of the population, nearly 90% here, are comprising of blast, and the rest of the cells are very few. These blasts are not expressing 1019, they are expressing 38, they're expressing 34, they're expressing myeloid markers like 33 and 13 and 36, but not the monocytic markers of 14 and 64. The blasts are expressing HLA-DR and 117, and CD15 is not there. Cytoplasmic MP is expressed in this case. 4 and 8 is negative, 356 are negative, and megakaryocytic markers are negative. So we have a blast population about 90%, which is expressing 34 HLA-DR and 38, which are markers of immaturity. It is expressing myeloid markers like 13, 33, MQ, and 117 with aberrant expression of CD7. And it is negative for monocytic markers and megakaryocytic antigens and other B and T cell markers. So the diagnosis given here was acute myeloid leukemia, and correlation with clinical and genetic data is recommended for complete WHO classification. AML is a clonal hematopoietic stem cell neoplasm characterized by a neoplastic proliferation of immature cells or blasts in bone marrow. There is block in maturation, and the blasts, the atypical cells can be blasts or atypical promyelocytes or chronocytes and monoblasts, which are all considered blast equivalents. So the revised fourth edition of WHO classification has these categories of AML, and this has been revised recently in the 5th revision. And I feel that the classification is now simpler. It is now into 2 categories only: AML with defining genetic abnormalities, wherein most of the abnormalities are the previous ones with a few new ones, and then AML defined by differentiation, and they have done away with the NOS category. But this NOS is very much similar to this category, AML defined by differentiation. Now case number 5, this is a 32-year-old female presented with bleeding PV for 10 days, epistaxis 3 days back, no organomegaly or lymphadenopathy. The peripheral blood findings include a hemoglobin of 7.8, WBC of 12,000, platelet of 12,000, DLC showing atypical promyelocytes or blast about 54%, and there were large cells with bilobe nucleus, granular cytoplasm with frequent OR rods and a few phago cells. So morphology itself is highly suggestive. This was the morphology of the cells. You can see that these cells have a bilobe or a buttock cell-like morphology with abundant granules in the cytoplasm. In fact, at places, the bilobe morphology cannot be seen also. On higher part, we can see that there is an phago cell, abundant granules and OR rods here. Again, same kind of cell. So although the morphology is very characteristic, sometimes we say that flow is not required for APML, but because we are starting with an ATRA, which is very important. It is very important to identify APMLs because we have a specific therapy for it, and the patients can be practically cured, and also because the patients can go into DIC and we can lose the patient. So PML RARA by PCR or by FISH will take some time, and flow will give us enough clues that it is actually an APML. Now look at this 45 versus side scatter. The blast here, they have got higher side scatter as we had previously seen. The blasts have got higher side scatter, and when we immunophenotype it, we can see that they are negative for the B cell markers, 19, 20, negative for the immaturity markers, 38 is negative, 34 is negative, 33 is homogeneous and brightly expressed. 3 and 7 are negative. 5 and 15 are negative. HLA-DR is expressed by a very small fraction. 117 is positive. T cell markers are all negative and cytoplasmic MPO is positive. Now, there were atypical promyelocytes on morphology. CD45 SAT scatter revealed 75% normal cells, which had moderate CD45, but also a moderate site scatter. These were negative for the immaturity markers and expressed the myeloid markers and cytoplasmic MPO, and these cells were negative for other monocytic B and T cell markers. And this was given as acute promyelocytic leukemia, and PML RARA came out to be positive on fish. So APL with translocation 15-17 has two variants, the classical hypergranular variant and hypogranular or microgranular variant. And we know the morphology, the nucleus is bilobed, and in both the types, but in the classical variant, it is the cells are granular. You can see OR rods, whereas in hypogranular, we do not see a lot of granules, but the bilobe nucleus can be seen. On careful search, some cells containing the OR rods or hypogranular type may be seen. The WBC is typically normal in APL with in the classical variant, but it's typically higher in the it is hypogranular variant. This is how a hypergranular variant looks like. These are multiple OR rods in a phago cell, and this is a hypogranular variant wherein you can hardly see any granules. Now, the immunophenotypic clues are firstly that the promyelocytes form a teardrop kind of a shape here, which I have discussed earlier. These cells are positive for 13 and 33, and they do not express the maturity marker, which is CD15. So when you look at this plot, you might say that these are maturing neutrophils, but then these neutrophils should be expressing CD15 here, which they are not. That means they are abnormal cell population. And they're expressing 117, which is a immature myeloid cell marker. 34 is negative, HLA-DR would be negative, and MPO would be positive. Now, case 6, this is a 40-year-old female presented to dental OPD with chief complaints of swollen gums. I think I'm running short of time. I think I'll go quicker now. This patient has been experiencing difficulty in swallowing food along with nausea, dizziness, and general malaise. She had swollen gums and gingival bleeding spots. The WBC count is 45, platelets are 14, and DLC showed 70% immature cells are blast. The blast now have a folded nuclei and lacy chromatin, and some blast with pseudopods and some blast with OR rods. This is the morphology. You can see these cells have more cytoplasm as compared to a typical myeloid blast. Some cells have got, blebbing or pseudopod-like thing, and some cells here resemble like promonocytes, and some resemble like myeloblast. On flow, the red population, blast population, it is positive for 34 and 38, the immaturity markers, positive for 33 and 13, the myeloid markers, and now it is also expressing 64 and 36, which is monocytic marker, but 14 is negative, suggesting that this is an immature monocytic population here. The cells are expressing cytoplasmic MPO and 117 and HLA-DR. The rest of the markers are 40 are negative. Look at CD4. This is expressed in some cells. Again, this can be expressed in monocytic population. Now, these are blast cells or immature cells on morphology. They express 34 and 38. They express myeloid markers like MPO 33, 117, HLA-DR 64, 36, and negative 14 and 15 with aberrant expression of CD56. So this was given as acute myeloid leukemia with monocytic differentiation, and correlation with clinical and genetic data is recommended for complete WHO classification. So those of you who want to go into details of a monocytic differentiation can go through this paper. Essentially, this paper tells us that even the monocytes will have this kind of a maturation pattern. So these are the most immature monocytes, the monoblasts, and these are the mature monocytes. So mature monocytes, while maturation, they will gain 14 and 35, and they will gain CD300E. These are more examples from this paper. I will not now discuss this because we're running short of time. This is 7th case, 60-year-old male with 15-day history of deterioration of health with generalized weakness, bone pain, petechial rashes. WBC was elevated, and there were 38% blasts like cells and dyspoetic nucleate in RBCs were noted. This is how the bone marrow looked like. Sheets of erythroid precursors predominantly comprising of pronormoblast. And this case has been picked up from the clinical flow, and this is not my case. Here you can see that the blast population is negative for CD45, and this is not expressing the classical myeloid markers, and this is highlighted by CD71 and glycophorin A, suggesting that this is a case of acute erythroid leukemia or AML-M6, in which there are more than 80% erythroid precursors on bone marrow, of which more than 30% should be pro-erythroblast. They are identified by the erythroid morphology of the blast, CD45 negative blast, expression of 71, 235A and 36, and on IHC, E-cadherin is positive. Another interesting case of a 7-day-old neonate who presented with umbilical stump bleeding, feeding intolerance, and bleeding in the form of hematemesis. He had hepatosplenomegaly but no lymphadenopathy. The child also had dysmorphic features suggestive of a Down syndrome. The patient had 37% WBCs and a platelet count of 46,000, and there were blasts on the peripheral smear. Although these blasts were not very much different from the myeloid blasts, some of them showed some eosinophilic granules, but not very classical blebbing or anything. On immunophenotyping, these blasts were positive for 34 and 33. The rest of the myeloid markers were negative. And look at this CD61, which is a megakaryocytic marker or a platelet marker, was positive in this case. TDT was positive in a fraction, MPO was positive in a fraction of these cells. So to summarize, these blasts expressed 34, 38 HLA-DR, 33, 61, and LIM71. Other myeloid monocytic B and T markers were negative. On cytogenetics, trisomy 21 or Down syndrome was confirmed. But then we were in a dilemma whether this is an AML, megakaryocytic, or something else. Patient was given repeated transfusions and started showing improvement after 3 weeks when the blast and TLC started to reduce. The thrombocytopenia persisted but gradually improved and finally recovered after 8 months. Patient is currently in remission, and a final diagnosis of transient abnormal myopoiesis with Down syndrome was made. And this is an interesting finding, diagnosed in approximately 10% of newborns with Down syndrome, usually presents with thrombocytopenia. And it should be differentiated from myeloid leukemia associated with Down syndrome, which usually is an acute megakaryocytic type. There is spontaneous remission in the first 3 months of life. Immunophenotypically, both entities are similar. This is the last case of a 28-year-old male admitted with fever, chills, petechial rash. WBC was high, platelets were low, there were 90% blast, and the blast here resembled 2 cell types. Some had a hand mirror lymphoid kind of a morphology, and some had a promonocyte and myeloid kind of a morphology. Look at this immunophenotyping here. The blasts are red, green are the limbs. The blasts are expressing 34 and 117, 13 and 33, 64 and 14, suggesting a myeloid and a monocytic maturation and an MPO. Then the blasts are also expressing 34, CD7 and cytoplasmic CD3. And you see that the normal T cells and the blast cells are expressing nearly the same amount of cytoplasmic CD3 and also CD7. CD4 and 8 were negative here. So these blasts express markers of myeloid monocytic differentiation as well as T cells. This was given as a mixed phenotype acute leukemia of T myeloid type, and genetic studies were suggested. In the 5th edition of WHO classification, they have added few more categories to the acute leukemia of ambiguous lineage category, and some refinement has been done in the intensity of staining for CD19 and other markers. You can go and look at that. So those of you who want to read further, there is this beautiful article on morphological and immunophenotypic clues to the WHO categories of acute myeloid leukemia. You can go ahead and read that. And this brings us to the end of my talk. To summarize, flow cytometry is an indispensable tool for acute leukemia diagnosis. It requires training at multiple levels: morphology, know your instrument, know your fluorochromes, know the markers and their maturation patterns. Blast enumeration can be misleading by flow, especially on bone marrow, and therefore morphology is the gold standard for blast enumeration. Flow cytometry is only a part of the workup, remember that, and complete diagnosis requires correlation of clinical, immunophenotypic, and genetic data. So I wish to thank all my colleagues, my teachers, my technical staff, my residents, Drs. Neha and Ruchita, who helped me in preparing this, and Dr. Ankita Jaiswal, who was a senior resident with us and is now a leading hematopathologist at Core Diagnostics. She has contributed a few cases. Also would like to thank the Cytometric Society of India and the International Clinical Cytometric Society.
So let's discuss what is approach to diagnosis of chronic lymphoproliferative disorder. So initially, I want to explain what is lymphoproliferative disorder. So any patient presenting with increased lymphoid counts with presence of multiple lymphadenopathy or associated or not associated with organomegaly, we always think we have to differentiate whether it's a benign increase in lymphocyte count or whether it's due to a lymphoproliferative cause, whether it's a malignant cause. So to differentiate a benign increase in the lymphoid cells from the malignant increase in the lymphoid cells, we need to differentiate, we need to do the immunophenotyping, which is done with the help of flow cytometry or with the help of immunohistochemistry. Now, as Dr. Namrata has explained, we prefer flow cytometry over immunohistochemistry. The reason being that flow cytometry gives a much faster result as compared to the immunohistochemistry. We can get the result within a single day, within 3 to 4 hours. Next, with the help of flow cytometry, we can detect the presence of multiple antigens on the same cells. So we can, suppose it's a B cell, we can detect whether the CD10, CD20, BCL2 all are present on a single cell, all are being expressed by the single population of cells. Second, the flow cytometry helps us to detect the presence of the weaker antigens. Now, these weaker antigens can be lost during immunohistochemistry when we do the tissue fixation and processing. So these are certain advantages of flow cytometry over immunohistochemistry. So let's proceed with the flow cytometric approach. So initially, when a patient comes, we have to be sure whether it's a lymphoproliferative disorder or not. Then we have to subtype whether it is B cell, T cell, or plasma cell disorder. Then flow cytometry also helps us in detecting whether there are any markers available for the targeted therapy, like CD20, whether it's expressed by the cells or not, because CD20 directed medicines are available like rituximab, and we have to check whether there are any prognostic markers available or not. We can use the various samples if the count is sufficient in the peripheral blood and if there are sufficient number of abnormal cells in the peripheral blood, we can do flow cytometry from the peripheral blood. If the count is reduced in the peripheral blood, we go ahead with the bone marrow aspiration. It can be done from the FNEC sample from the lymph node or from the tissue mass. We can use the body cavity fluids like the peritoneal fluid or pleural fluid and even CSF to assess the type of malignant cells present. And we can also use the biopsies from the lymph node, that is solid organ biopsies or the lymph node biopsies, wherein we can make a single cell suspension from the solid organ and we can use that for doing the flow cytometry. So the lymphoproliferative disorders are broadly classified into B cell type and T cell type. So initially I'll be discussing the B lymphoproliferative disorder. So how do we identify whether the B cells that are present here are abnormal B cells or the normal reactive B cells? So the most important thing is to check for the presence of immunoglobulin light chain class restriction. So if there is any abnormality in the kappa to lambda ratio, if it is altered or if both are absent, we suggest that these are the abnormal or the clonal mature B cells. Next is the presence of the aberrant antigen expression. By aberrancy, we mean the expression of the antigens that are not normally expressed by that lineage. Suppose B cells start expressing CD5 or they start expressing myeloid markers like CD13 or CD33. It is called as aberrant expression. Now, if I discuss about a normal lymph node, the germinal center B cells are positive for CD10 and the mental zone cells are positive for BCL2. But if we get a population of B cell that is expressing both CD10 and BCL2, we know that it is definitely an abnormal population. Or if the B cells start expressing CD5. Similarly, the altered intensity of staining also gives a clue whether the cells are abnormal or the normal proliferation. Like if there is dimmer or absent expression of CD20, dimmer or absent expression of other B cell markers like CD79 and CD22, then it gives us a clue that the cells we are dealing with is an abnormal population of cells. Coming to the gating strategy, as Dr. Namrata said that for acute leukemia, we commonly use CD45 versus side scatter for gating. It helps in differentiating the blast cells from the normal population of cells. When we talk about the lymphoproliferative disorder, we use a gating marker. Suppose it's B lymphoproliferative disorder is suspected, we use CD19 versus forward scatter versus side scatter as a gating marker, CD19 versus side scatter. So with the help of the CD19, we'll be able to pick up all the B cells. So the cells that will be 19 positive will be B cells, and the cells that are 19 negative will be mostly the T cells and the other cells. Similarly, for T lymphoproliferative disorders, after the basic panel, we can use either CD4 or CD8 or CD3, depending on the basic panel. Any of those can be used as a gating marker. But here, one thing I want to point out is that the peripheral smear or the bone marrow smear that we make gives a very important clue. If we are able to identify from the smear that we are dealing with the mature lymphoid neoplasm, we directly go ahead with the gating with the CD19 versus side scatter. But if there is some amount of confusion whether we are dealing with a mature lymphoid neoplasm or these are immature cell, we still proceed with CD45 versus side scatter. So in my presentation, I'll be showing the cases of both the types. Like in some cases, we have done CD19 versus side scatter gating. In some, we have proceeded with CD45 versus side scatter gating. So further to discuss about how to approach this B cell lymphoproliferative disorder, this is an algorithm that gives a clue. Initially, we check for the presence, after gating with CD19, we check for the presence of CD5 in the gated population. If the CD5 is positive, we check for the presence of CD23 and FMC7. CD23 positive and FMC7 negative points out towards chronic lymphocytic leukemia. If CD23 is positive and FMC7 is also positive, it is pro-lymphocytic leukemia. Of course, we have to correlate with the presence or absence of other B cell markers also. This is just about few important markers which can help us in reaching a diagnosis. Now, if CD23 is negative and FMC7 is positive, along with, of course, cyclin D1, it's the mantle cell lymphoma. Okay. Okay, if CD5 is negative, we look for the presence of CD10. Now, all of us know that CD10 is a germinal center marker. So, all those lymphomas which have a germinal center origin will be positive for CD10. So, when CD10 is positive, along with the presence of other markers, it could be either follicular lymphoma or diffuse large B-cell lymphoma or Burkitt's or BLL. If CD10 is negative, we proceed ahead with another tube containing the hairy cell markers like CD103, CD125, and CD123. If these come positive, it's positive, then it's hairy cell leukemia. If these markers are negative, we think about other lymphomas which can have fuzzy cytoplasmic borders like splenic marginal zone lymphoma, the lymphoplasmacytic lymphoma, hairy cell leukemia variant, and even diffuse large B-cell lymphoma. There is another approach also wherein along with the CD5, we can check for the presence of CD10 and we divide the cells lymphomas as 5 positive, 10 negative lymphoma, 5 positive, 10 positive lymphoma, 5 negative, 10 positive lymphoma, and 5 negative, 10 negative. Like in the 5 positive, 10 negative lymphoma, we have SLL/CLL, mantle cell lymphoma, prolymphocytic leukemia, marginal zone lymphoma, diffuse large B-cell lymphoma, and lymphoplasmacytic lymphoma. 5 positive, 10 positive lymphomas are all the germinal centers like follicular lymphoma, diffuse large B-cell lymphoma, mantle cell lymphoma, Burkitt's lymphoma. 5 negative, 10 positive, here we have follicular lymphoma, DLBL, Burkitt's, and of course there is some certain amount of overlap between each category. In 5 negative, 10 negative lymphomas, we have hairy cell leukemia, marginal zone, diffuse large B-cell lymphoma, and mantle cell lymphoma. Okay, this is a chart. It's a rather busy slide showing the expression of various markers. When we talk about the 5 positive lymphomas, the expression of surface markers like CD20, CD79B, CD22 play a very important role. If there is dim expression or absent expression of these markers, along with a very bright expression of CD200, this is classically seen in chronic lymphocytic leukemia. So when and these markers like B cell markers CD22, FMC7, 79B, and 22 are brightly expressed in mantle cell lymphoma. When we talk about CD200, it is brightly expressed in, it is characteristically, I can say characteristically brightly expressed in chronic lymphocytic leukemia and hairy cell leukemia. Other places, either it can be dim or absent in most of the places. And then we have certain markers for the cells which have certain cytoplasmic projections called as the hairy cell markers like CD103, CD123, CD11C, and CD25. So I'll be telling about the expression of these markers in various lymphomas when we discuss the particular cases. So as initially mentioned, the cytomorphology plays a very important role. So we always, before starting with the flow cytometry, we always make a smear from the blood and check for the morphology of the cells. Whether the cells are small size, medium size, or large size, what is the kind of cytoplasm, what is the kind of nucleoli. And this gives us a clue whether we are dealing with a mature neoplasm or the blastic neoplasm. In mature neoplasm also, whether it's a small cell type or a large cell type. Like the small cells with scant cytoplasm are seen in chronic lymphocytic leukemia, mantle cell lymphoma, marginal zone lymphoma, and low-grade follicular lymphoma. Those with moderate cytoplasm with fuzzy borders are seen in hairy cell leukemia and splenic marginal zone lymphoma. Eccentric nuclei is seen in lymphoplasmacytic lymphoma and at times in marginal zone lymphoma. And we can get deeply cleaved cells, small cells with deep cleaving is characteristic of the follicular lymphomas. Plus, we can have a blastic conversion in certain types of lymphomas. At times, we see large cells. These large cells may or may not have vacuoles. These large cells are characteristic of diffuse large B-cell lymphoma. And even DLBL cells can have vacuoles. Other than diffuse large B-cell lymphoma, the Burkitt's lymphoma cells can have vacuoles. So cytomorphology plays a very important role. This is the 8-color CLPD panel that we are following in our lab. So we use CD19 as a gating marker and add various markers like CD23, CD10, CD5, CD200, 38, 20, and of course a 45 to check for the expression of whether the 45 is bright in the gated population or not. Other than that, we add FMC7, the various T cell markers like CD3, CD8, CD7, CD2, CD4. And to check for the clonality, we use lambda and kappa. And when required, depending on the morphology or depending on the patient's history and the clinical presentation, we add this tube containing the hairy cell markers. So with this basic knowledge, I will be discussing few important cases. This is a case 1. It's a 60-year male with leukocytosis. So we made a peripheral smear. In the peripheral smear, you can make out the lymphocyte count is markedly increased and there is presence of plenty of smudge cells in the background. So looking at the peripheral smear itself, we can make out, okay, we are dealing with a chronic lymphocytic leukemia. So let's see what we got on the immunophenotyping. So on this plot, we have gated the singlet cells, and this is a plot to gate all the nucleated cells. Now further we subgate this, the population of interest And since we knew it's a CLL, it's a B cell, probably it's a B cell lymphoproliferative disorder, we decided to proceed with the CD19 gating. So on CD19 versus site scatter, we see a population which is a bright 19 positive. So this is a population of interest. So we have gated this. This is a 19 positive cells and here is the 19 negative cells. So 88% cells we gated on bright CD19 positivity. So let's see what is the expression of other markers. On 23 versus 19 plot, we can make out there is a heterogeneous expression of CD23. Now, what do we mean by the term heterogeneous expression? Heterogeneous expression means certain cells are negative for CD23, some are expressing it dimly, and some are expressing bright 23 marker. So this is called as the heterogeneous expression. Next plot is showing CD5 versus CD19. We can make out all the 19 positive cells are brightly CD5 positive. Now, as Dr. Namrata said, there are two methods of gating. Either you can put a quadrant and check whether the cells are positive for that particular marker or not, or you can compare it with the normal internal control population to check the presence or absence of a marker. Since these were 19 negative cells, this could be either 19 negative cells in a sample, could be the T cell or it could be debris. Now, these cells which are brightly 5 positive are the T cells, and we can make out our population of interest is expressing CD5 up to the same level. So our cells were brightly CD5 positive. When seeing the CD38 versus CD19, CD38 expression is absent. Someone has put the annotation marks on the screen. Please, if you can remove them. The yellow color annotation marks, please remove them as they are interfering with the presentation. Okay, now looking for the FMC7 and CD20, we can see the CD20 is not very brightly expressed. There is some heterogeneous expression of CD20. There are some cells here which are normal B cells which are very bright 20 positive. If you compare with that, 20 is almost like very dim expression of CD20, dim and heterogeneous. FMC7 is absent. When we talk about CD200, it is very bright. Now on this plot is showing the T cell markers. These are the normal T cells which are present, which are acting as internal control, and they are helping us to tell whether the our population is expressing that marker or not. So our cells were had no expression of CD7, CD3. They had absent CD4 and CD8. And when we checked for the clonality, there was very dim expression of kappa. So we are dealing with a population which is bright 19 positive, very bright 200, and CD5 positive. CD20 is very dim, 23 is heterogeneous with dim kappa expression, negative FMC7 and negative 38. All the T markers were negative and correlating with the peripheral smear image that we got. So it's a case of chronic lymphocytic leukemia. So here an important point on how to differentiate chronic lymphocytic leukemia from pro-lymphocytic leukemia. At both places, CD5 is brightly positive. But when we compare the CD200, CD200 is very bright in cases of chronic lymphocytic leukemia, and 200 is absent in pro-lymphocytic leukemia. CD20 and CD79B are very dim in chronic lymphocytic leukemia. This is called as abnormal antigen expression. That is the normal B cells losing the B cell markers like CD20 and 79B. It's a characteristic of chronic lymphocytic leukemia. But when we talk about pro-lymphocytic leukemia, here the cells are CD20 and CD79B positive. To check for the other markers, CLL, CD23 is positive, whereas in pro-lymphocytic leukemia, CD23 is negative. Moreover, the pro-lymphocytic leukemia on the peripheral smear will have a very high count, and more than 55% of the cells will be pro-lymphocytes. These are large cells with very prominent nucleoli. So just to talk about the mantle cell lymphoma, the mantle cell lymphoma are classically positive for CD5. Why I have put mantle cell lymphoma here along with CLL and PLL is to discuss about the 5 positive lymphomas. Here we have 5 positive, 19 positive, 20 and 79, both are brightly positive. but there is absence of CD200, absence of CD23, and when on the when refined biopsy later on, when we get and we process, we check for the presence of cyclin D1. If cyclin D1 is positive or the SOX11 positive, it's mantle cell lymphoma. Moving on to the case 2. Here is a 47-year male patient with weakness, joint pain, abdominal discomfort with palpable spleen and liver and cervical and axillary lymphadenopathy. Now this is the smear which has been made from the peripheral blood. You can make out these are all the small cells, and some of them have got a deeply cleaved nucleus, a very deeply cleaved nucleus. The count was very high. There was a flagging in the 3-part cell counter. The platelet count was reduced and hemoglobin was raised. So we processed this sample on the 5-part cell counter, and now we are getting a hemoglobin of 6.2, WBC count of 8 lakhs with a reduced platelet count. These are the bone marrow smears, which is showing a very hypercellular fragment and a similar kind of cells of small size with deeply cleaved nucleus. Here we plan to proceed with CD45 versus site scatter gating. As you can make out on the CD45, we are seeing two kind of populations. One population is brightly CD45 positive and other population is dim CD45 positive. So we gated both the populations. We have put a gate here and we have put a gate on the bright 45 positive population. And in this case, we proceeded with the acute leukemia panel, because since we got a 45 dim positive population, we were like, are we dealing with the acute leukemia or it's a mature lymphoproliferative disorder? So initially we proceeded with the acute leukemia panel. So let's see what we got. 34, which is a marker of immaturity, is absent. These cells are expressing CD10. Now, how do we know whether our CD10 is positive or negative? For that, we have the granulocytic cells as the internal control. Our maturing granulocytic cells express CD10. So these are the granulocytic cells. In comparison to these CD10 positive cells, when we check our population of interest, we can see that our cells are also CD10 positive, as well as they are expressing CD19. The internal control of CD19, some amount of green cells are seen here, which were gated here. So these are the B lymphocytes, which are again 19 positive. You can make out CD20 is bright positive with heterogeneous expression of CD38. Let's see CD5. CD5 is almost negative. CD8, the T cell markers, here is a main chunk, the main button, the CD8 and CD2 are negative. In some cells, we are seeing the expression of 8 and expression of 2. This could be the normal T lymphocytes, which were gated along with the population of interest. There is absence of CD3. There is absence of the myeloid markers. This is the internal control, that is granulocytic cells, positive for 64. And we can see our population of interest has absent 14 and 64, absent 117. There is expression of HLA-DR, bright expression of HLA-DR, absent 13 and 33. The MPU is negative when compared to the internal control, that is granulocytes. CD22 is almost brightly positive and cytoplasmic CD3 is negative. The TDT is negative. So, and CD99 is negative. So we can make out all the immaturity markers are negative. So we are not dealing with acute leukemia. We are dealing with lymphoproliferative disorder. So again, we proceeded with a clonality tube. There was absence of kappa and lambda. So what do we have? We have a bright 19 positive cells, positive for CD20, CD10, CD38, CD20 of course was positive, CD22, HLA-DR, negative for T markers, myeloid markers, immaturity markers, kappa and lambda. So here we are looking at the cytomorphology, also looking at the deeply cleaved nucleus. We are dealing with the follicular lymphoma in leukemic phase. Now, one important thing I want to point out here is that in our lab, whenever we have got the cases of follicular lymphoma, we have always noticed that they are slightly dimmer 45 positive. Even the literature says that the follicular lymphoma, I haven't found a comment on CD45 in the literature, but literature says that the follicular lymphoma cells are slightly dimmer positive for CD19. This is the trypine sections that we got later on, a hypercellular trypine section showing complete replacement of the normal hematopoietic stroma by the abnormal lymphoid cells of small size. This is third case, 52-year female with dry cough and chest pain. She was a follow-through case of pancreatitis and had a 8 centimeter palpable spleen. WBC count was almost in the normal range, 7,400. Platelet counts were normal. This is the smear. On bone marrow examination, we got a very scanty aspirate and we made the smear with that. We can make out there is presence of these abnormal lymphoid cells, and some of them have this classical morphology, the fuzzy border, and these are the flow plots. So we gated on site scattered versus CD19, and we have gated a bright 19 positive cells, which are approximately 50%, and these cells are positive for CD23, absent CD10 expression. They are very bright CD200 positive. CD38 was almost absent. They were bright positive for CD20, CD5 was absent. So we checked the presence of FMC7. There is no FMC7 expression. CD123 is brightly expressed in these cells. There is absence of T cell markers 7, 3, 4, and 8. There is expression of CD25 and CD103. So we are seeing the expression of CD25, CD103, CD123, CD56 is absent. And when checking for the clonality, almost equal expression of lambda and kappa. So we are dealing with a B cell population that is expressing CD20, very bright CD200, and other hairy cell markers like CD103, 123, 25, and negative for all lymphoid markers. So this is a case of hairy cell leukemia. So after another few slides, I'll be discussing the expression of comparison between the hairy cell leukemia and the other BCLPD. So before that, I'll be discussing one important case. Now, this is a case for 65-year female with anemia and splenomegaly. This is a smear. We can see increase in the lymphoid cells of almost same size that of the RBCs or slightly bigger than RBCs, we can see. This is a closer view. We can see some projections. And this is a plot when getting with CD19 versus site scatter. We see 36% cells positive for CD19. Let's see what these cells are expressing. These cells are very bright 20 positive. As you can make out, the 20 is like, it's coming on very top. They are very bright 20 positive, absent for CD5. They are bright 45 positive. They are bright CD19 positive. And there is, for 38, there is a heterogeneous expression. We can see CD200 is absent, but FMC7 is very bright. There is bright expression of CD23. And of course, the T cell markers 7 and 3 were absent. There was absence of CD10. There was some amount of expression of 11C, but most of the cells were almost absent. When comparing the 25 versus 103, the cells were expressing 103, but 25 was absent. And on clonality, these cells were positive for lambda. So we have a 19 positive cell population, which is expressing very bright CD20, bright 45, heterogeneous 38, some amount to 23, and other markers like 103, FMC7, CD22, CD11C, lambda. And these cells were negative for CD200 and CD25. So correlating this with the peripheral smear, with the bone marrow images, we came to a clue that these cells are, we came to the conclusion that these cells are, this is a case of hairy cell leukemia variant. Now, this slide is just to show the difference between the classical hairy cell leukemia and hairy cell leukemia variant. So these patients present with very low WBC count, whereas the variant present with increased WBC count. Moreover, morphologically, when we see the variant cells will have prominent nucleoli as compared to the classical hairy cell leukemia cell. On immunophenotype, our hairy cell leukemia is very bright CD200 positive, whereas the variant is 200 negative. The CD25 and CD123 are very bright positive in hairy cell leukemia, And these two markers, the 25 is absent in hairy cell leukemia variant, and there is dim expression or absent expression of 123. And of course, CD103 is present in both the classical hairy cell leukemia as well as the hairy cell leukemia variant. So looking at the presence of CD203, looking at the presence of CD200, looking at the presence of CD25 and 123, we can subclassify the case whether it's a classical hairy cell leukemia or a variant immunophenotype. Now, another category which present with the cells with having the fuzzy borders or the bipolar cytoplasmic projections is the splenic marginal zone lymphoma. So these splenic marginal zone lymphoma, the cells are 11C positive and very bright positive. Here also the 200 will be negative. So 200 is negative in splenic marginal zone lymphoma as well as the hairy cell leukemia variant. Another very important marker, although this we are not using in our lab, is CD305. This CD305 is very bright positive in hairy cell leukemia, whereas it is absent in the splenic marginal zone lymphoma. And of course, another category is mantle cell lymphoma. These mantle cell lymphoma cases can also be CD11C positive, 200 negative, and 305 positive. And of course, when we get the trifine section, we have to put cyclin D1 or SOX11 to check for the presence of or absence of these markers to classify as it into the mantle cell lymphoma. This is a class 5. This is a case 5. Here we decided to gate on CD45 versus site scatter. So most of the population, we are getting a single button here. We gated it into this P1 gate or the population of interest. These cells are brightly positive for CD19 and absent for CD10. As I told you, for CD10, the internal control is the granulocytic cells. So these granulocytic cells are brightly positive for CD10. So when compared, our population is 10 negative. There is absence of the immaturity marker CD34. There is heterogeneous expression of CD38. CD25 is negative. Bright expression of CD20. The T cell markers CD3 is absent. This must be some normal T cells which got gated on the CD45 versus site scatter plot. See, when we are getting here, we might be getting some normal T cells and as well as the normal B cells as well. So there is heterogeneous expression of CD2. There is almost negative expression of CD7 and CD5. Cytoplasmic CD3, MPO is absent. TDT is absent. So this is not an immature neoplasm. All the immaturity markers are absent. The myeloid markers are absent. This is a normal internal control granulocytic cells and the monocytes, which are brightly positive for 1333. 64 and 14 are absent. 117 is absent. And there is absence of HLA-DR. So if we further put one tube with the 19 as a gating marker, there is absence of the T cell markers. FMC7 is like almost there is heterogeneous expression of FMC7. 200 is absent, CD5 is absent, and these cells were brightly expressing kappa. So definitely this is a clonal population having the expression of B cell markers and negative expression of CD200. So what is this? We have bright 20 positive, bright 19 positive, 45 bright positive, FMC7 and kappa positive population. And the other markers like 200, 23, the T markers 4, 8, 3, 7 were absent. 25 was absent. The germinal center marker was absent. Immaturity markers were absent and absent myeloid markers. So here we are dealing with a 5 negative, 10 negative chronic lymphoproliferative disorder. And probably since we saw the prominent nucleoli, we thought, okay, this could be the blastic transformation. So then we further advised other markers on trifine section like BCL2, Ki67 and BCL6. So this is a trifine section that we got, this HNE view. So BCL6 is absent, cyclin D1 is absent, and BCL2 is also absent. So probably we were dealing with the marginal zone lymphoma. This is another case, 33-year male with recurrent vomiting and weight loss and pain abdomen. CT abdomen showed eccentric heterogeneous lesion in third part of duodenum up to the duodenojejunal junction. Patient had mesenteric and retroperitoneal lymphadenopathy with pelvic ascites And this patient had already received 1 cycle of R-CHOP at a private center. So this is a peripheral smear showing increased count with the increased lymphocytes. The bone marrow aspirate was diluted. So this is an imprint smear, which is definitely showing increased number of lymphoid cells. Again, we plan to gate on 45 versus side scatter. This is, we put 2 gates here depending on the 2 different buttons that we got. And probably the red one is a population of interest. So these cells are expressing CD22 as well as CD10. And as I told you, CD10 is a germinal center marker. So here itself we got to know, okay, maybe we are dealing with one of the germinal center lymphomas. CD200 is, CD23 is negative. CD19 is very bright positive. There is absence of CD5, CD2. There is expression of CD38, CD23 is negative. The 34 is negative, FMC7 is positive, CD200 is negative. And further we gated for with the CD19 to check for the clonality, and these cells have expression of lambda. So this is a clonal population with lambda expression. And of course, these are the plots showing the T cell markers like 4 and 8 negative, TCR gamma delta negative population, as well as 3 negative. So we can make out we are dealing with a bright 45 positive population, which is expressing the B cell markers like CD20, a germinal center marker CD10, CD19, FMC7, 38, and it's a clonal population expressing lambda. Negative for CD23, CD200, other T cell markers, immaturity markers, and gamma delta. So it's a 5 negative, 10 positive lymphoma. Later on, we reported it as B chronic lymphoproliferative disorder, 5 and 10 negative. And because of big size of the cells, we wrote it as probably diffuse large B cell lymphoma. Let's see what we got here. This is the biopsy from the duodenal junction, the mass present there. We can see the ulcerated mucosa and diffuse infiltration by the lymphoid cells here. We proceeded with the IHC on this. We can see the cells are brightly positive for 20, 10. BCL6 is very bright positive here in more than 90% of the cells. The Ki67 is very high, around 90%. MUM1 is being expressed by around 30% cells, I can say. And BCL2 is getting expressed by almost 90% cells. So this is a case of diffuse large B-cell lymphoma, and this is a trephine biopsy of the same case, showing the infiltration by similar kind of cells on the trephine section. So in my presentation, I have tried to correlate flow cytometry with the tissue biopsy, so that you can correlate how we get to see in the flow cytometry and how we get to see the population of interest on the immunohistochemistry slides. This is a case 7, 60-year male with bilateral cervical lymphadenopathy, abdominal ascites. So in this case, we tried FNAC flow cytometry from the cervical lymph node. Now, FNAC flow is usually like whenever we get a patient with lymphadenopathy and we see the patient is sick, we proceed with the FNA flow rather than waiting for the tissue biopsy and IHC, because flow will give a faster result. So for the FNAC flow, what we do is that we do the FNAC from the lymph node and we collect the sample in the EDTA vial. This EDTA vial we fill up with around 2 ml of the sheath fluid. Sheath fluid is the we use for the flow cytometry. It's the normally available in all the flow cytometry lab. So we take the 2 ml of sheath fluid in the EDTA vial, we do the FNAC and collect the sample in the sheath fluid, and we make a single cell suspension from that. And one care we have to take is that FNA flow should be processed as soon as possible after collecting the samples. So these are the FNA smears. We can see the increased number of cells here, the lymphoid population. And this is a closer view showing the presence of this abnormal lymphoid population. We can make out there are some large cells, some histiocytic cells, some small cells here. So this is 45 versus side scatter gating. We are seeing this population here. These population cells are positive for 19, absent 10, absent 34, positive for CD38. T cell markers 5 and 3 and 8 and 4 and 2 were absent. And these cells are brightly positive for CD22. Immaturity marker 19, TDT was absent. And on 19 versus 45, we getted the bright 19 positive population. and there was some expression, this population was clonal for kappa. So we are dealing with a B cell population showing kappa clonality, negative T markers, negative CD10 and negative CD20. Okay, on this plot, you can see the CD20 is negative. So it is a 5 negative, 10 negative chronic lymphoproliferative disorder. Later on, we did the bone marrow aspirate and we saw these cells in the bone marrow aspirate. These are the trifine sections showing infiltration by similar kind of cells. We received the lymph node biopsy. The lymph node biopsy is showing the presence of certain large cells with a small cell rich background, some amount of necrosis here. CD20, as we can make out, it's positive in all the large cells. The background small cells are positive for CD3. There was a very high Ki67. And this is the CD68, which is dealing with the, which is highlighting the histiocytic cells. The other markers like BCL6, CD10 were negative, CD30 was negative, 34 was negative. So this was a case of T histiocyte-rich large B cell lymphoma. So from the flow, we could come up to a conclusion that it's a 5 negative, 10 negative lymphoma, and probably the large size cells were there. So it's one of the large cell lymphomas. This is case 8. 61-year male with hypertension with chronic kidney disease. There was no organomegaly or lymphadenopathy. And the patient underwent bone marrow to rule out the plasma cell disorder. Hemoglobin was 7 gram% with 6,000 TLC and 64% atypical lymphoid cells. This is a smear showing the bone marrow aspirate smear showing the presence of the atypical lymphoid cells with some amount of cytoplasm. The gating on CD19, positive 19 population gated, showed a very bright expression of CD23, absent CD10, absent CD5. These cells were very brightly positive for 200. 38 was almost negative. 20 was bright positive. And as I told you, very bright 200, you should think of CLL or hairy cell leukemia. 45 was very bright positive. FMC7 was positive. And lambda, there was expression of lambda. But we are ruling out CLL here because 20 is very bright positive. Usually CLL don't have this bright expression of CD20. So we were like, either this is a case of hairy cell leukemia or marginal zone lymphoma. At times the marginal zone lymphoma can have 200 expression, but usually it is not this bright. So this case was reported as B chronic lymphoproliferative disorder, query hairy cell leukemia or query marginal zone lymphoma. Patient presented after 2 years with severe thrombocytopenia, still no palpable spleen, rising creatinine of 6 mg per deciliter with a TLC of 6,000 and 49% atypical cells. So this time, again the same immunophenotype, bright 20 positive, heterogeneous 23, absent 10, absent T cell markers, TCR gamma delta 5, FMC7 was positive, 200 was very bright positive. So this time we proceeded with the hairy cell tube. CD25 is positive with absence of CD103. There is very bright expression of CD123 and a bright expression of 11C. So as I have told you in the previous slide, usually hairy cell leukemia, the classical as well as the variant are 103 positive. Here we are getting the expression of all the hairy cell markers except for 103. So probably this is a case of 103 negative hairy cell leukemia, or still a marginal zone lymphoma can be kept into the differential. So this was about the B lymphoproliferative disorders. Now, I think I have another 10 minutes left, so I'll be telling you about the T or NK cell lymphoproliferative disorder. So again, just to emphasize the same thing, how do we know that we are dealing with the abnormal T cell population? This could be assessed with the help of aberrant T cell antigen expression, like lack of pan T cell antigens, like absence of CD5, absence of CD7, or with the help of the altered intensity of staining, or expression of certain non-linear specific markers like CD15, CD13, CD33, or identification of restricted population of T cells which have altered 4:8 ratio, or positive for either 4 or positive for either 8, or a double positive population like population which is both CD4 and 8 positive, or a population which is dual negative for both 4 and 8. And a predominant population of TCR gamma delta cells. Then we have to check for the presence of NK cell associated antigens like CD16, CD56, and CD57. So this is the algorithm we followed for T lymphoid cells. Based on 4 and 8 expression, we divide them into 4 positive, 8 positive lymphomas. These are TPLL, angioimmunoblastic T cell lymphoma, LGL, peripheral T cell lymphoma. 4 positive, 8 negative lymphoma. Here again you have a battery of lymphomas like Sézary syndrome, ATLL, PLL, ALCL. Then 4 negative, 8 positive lymphomas like TLGL is there, hepatosplenic T cell lymphoma is there, and the lymphomas which are double negative for 4 and 8. So here you have nasal T or NK cell lymphoma, aggressive NK cell lymphoma, these cells. And this is a chart. This is a chart which is showing the expression of other markers in these lymphomas like 4 positive, 8 negative lymphoma. If it's 7 negative, 26 negative, 25 positive, we think of Sézary syndrome. If it's negative for 16, 56, 57, we think about TPLL. If it's positive for 25, absent 7, we think about adult T cell leukemia lymphoma. In anaplastic large cell lymphoma, there is loss of pan T cell antigens and strong uniform expression of CD30. With CD56 positive or negative, aberrant expression of CD13 and 33, we think about anaplastic large cell lymphoma. Similarly, the 4 negative, 8 positive lymphomas, here along with the other expression, co-expression of other markers or absence of markers, we further subclassify. These are the lymphomas which are positive for both 4 and 8. Here we have TPLL, adult T cell leukemia lymphoma, and peripheral T cell lymphoma. And the cells, the lymphomas which are double negative for both 4 and 8. Here we have enteropathy associated lymphoma, hepatosplenic T cell lymphoma, and non-hepatosplenic T cell lymphoma. So just to discuss 2 cases of T cell lymphoma, a 57-year female being evaluated for pancytopenia and 4 centimeter palpable spleen. So this is a peripheral smear. We can make out these large size lymphoid cells. The count is not very high, and we can see the cytoplasm is having some fine granules in it. This is a closer view showing the granular cytoplasm here, the irregular nucleus, occasional prominent nuclei, and the granular cytoplasm. So we gated on 45 versus site scatter initially. On in this, we okay, so now you can hear me. These cells are brightly positive for CD2 and CD3. There is heterogeneous expression of CD56. So when we get a bright 3 positive population, they are showing the expression of CD2, as well as some cells are showing the expression of CD8. So on the further plots, we further subgated this 8 positive population to check for the presence of other markers. This 8 positive population is showing the expression of CD2 and CD3. So we are dealing with a T cell lymphoma, which is positive for all the T cell markers, CD3, CD5, CD8, CD2, CD56, and there was loss of these cells are not expressing the CD4, and negative for B cell markers and immaturity markers. So correlating with the peripheral smear, this was a case of T large granular lymphocytic leukemia bar lymphoma. Now the next case, 50-year female, you can make out the increased lymphocyte count and lymphocytosis. Again, we have gated some mature lymphoid cells, some cells in the blast cell region, and some cells here. There was a bright button here, so we plan to get them as well. And we see, okay, so bright positive cells are your mostly the lymphocytes, some cells in the blast cell region. Let's see what they are expressing. So there was bright expression of CD7, CD19 was absent, 34 was absent, 10 was absent, 20 was absent. But when we checked the cells which were present in the blast region, they were positive for CD10. Some were expressing CD34 and some were expressing CD20. So as Dr. Namrata said, we should be cautious about the presence of hematogones. So what we have gated in P1 region are probably the hematogones. Okay, so let's see the population of interest. Most of the cells are negative for both 4 and 8. So we are dealing with a 4 negative, 8 negative lymphoma. And these are expressing CD2, CD3 bright expression. And okay, we further subgated this 4 positive, 8 positive population just to check accurately. So they were positive for CD2, CD3, absence of TCR gamma delta, and they were bright positive for 56. We had put a myeloid tube also. This is showing the absence of all the myeloid markers. So this is the immunophenotype that we got. So this we labeled it as T lymphoproliferative disorder. So with this, I would like to end my presentation. I hope I have covered B lymphoproliferative disorders and T lymphoproliferative disorders. I would like to thank my entire team of the King George's Medical University, my technician Hirendra, who is doing most of the processing, my co-faculty members, and last but not the least, I would like to thank all the patients who have made me learn. I would like to thank the Flowcytometric team from various institutes from where I have got trained to gain this knowledge. Thank you all.